Hi, Michael. How are you?
Hey, how are you doing? How's everything in Mexico?
Oh, well, it could be better, but I see that you're really enjoying the summer.
Listen, you have to enjoy what you get nowadays.
Yeah, yeah, you look tan. I'm having trouble with my internet, so I hope I don't mess the whole program. Welcome, everybody. This is a live program originated in Mexico City and New York City, where Michael is living. The weather in Mexico City is 19 degrees Celsius. In New York City, it's 29. Wow, it's nice to get on the rooftop and get some suntan.
You should come and get the suntan, man, from Mexico.
Well, I don't know. I don't know if can you hear me?
I can hear you.
Okay. Some things is happening with internets. Well, anyway, now I can see everybody. Sorry. I had to connect through my telephone because the internet at home just went dead. And nowadays it's really, really hard. And I'm really looking forward to this program, Mike. I think you invited really two top people to talk about what everybody wants to know. It's like that Woody Allen movie, everything you wanted to know about COVID, but you were afraid to ask. This is the night to ask every question you had on this.
Yeah, we're fortunate enough. Thank you, Craig and Perry, for joining us. We're going to talk about the virology itself, the science behind it. And then Perry, who is an MD, will talk about his experience in treating COVID-19 patients. So you're going to have the science behind it, the clinical part of it. And I'm very much looking forward to all the interactions with the audience here, because your questions are really what make this program as valuable as it is.
Okay, so without much to say, I think we gonna go to a very short video, and we'll be right back with our guests.
Observa el estado de la salud de la cavidad bucal mediante la detección de actividad bacteriana de una forma más clara, sin la necesidad de utilizar agentes externos. Visualiza placa dentobacteriana activa y no activa. Microfracturas, filtración de restauraciones, caries, desmineralización, valoración de estado periodontal, valoración de prótesis dentales, zonas retentivas de placa dentobacteriana. Auxiliar visual para el paciente. Funciona a través de la tecnología QLF, que incide la fluorescencia sobre uno de los elementos residuos de las bacterias. La porfirina que se revelará en el filtro de la pantalla, marcando un color más rojizo, dependiendo de la cantidad de porfirina presente, lo que diferenciará la placa nueva de la placa vieja, así como las zonas de gran actividad bacteriana. Encuentra esta poderosa herramienta para llevar a cabo todas tus mejores ideas dentales.
Okay. Hi, Perry. Hi, Craig. How are you?
Very well. Thank you.
Thank you for joining us. Perry is in New York City, and Dr. Craig Miller is in Kansas City, right?
Close. Kentucky.
Or San Luis,
Lexington,
Missouri.
Kentucky.
Where is it?
Lexington, Kentucky.
Lexington. Sorry. Okay. So, Michael, you know this tonight's guest better than me. So, why don't you introduce him to the audience, please?
Right. So, Craig, officially, I've known Craig for many years, and without getting too much detail, so I'm going to talk a little bit more about him later on. But Craig is a distinguished professor, Alvin L. Morris Professor of Oral Health and Research and Chief of Division of Oral Diagnosis, Oral Medicine, Oral Radiology at the University of Kentucky College of Dentistry. And he has authored hundreds, over 300 scientific articles, abstracts, textbook chapter, monographs, editorials in the discipline and specialty of oral medicine. And I think one of the most impressive things with Craig is that he is not only a clinician, but he's also a highly regarded researcher, specifically in virology, with enormous amount of grants from both from the National Institute of Health and other places. He has authored several textbooks. The one that you probably are most familiar with is the dental management of medically compromised patients, that every dental school in the world, I think people are reading that book, Craig. So congratulations on that one, obviously. And at the present time, Craig is also now a Robert Wood Johnson Scholar, where he is doing some very interesting things that maybe he can talk a little bit about later. But it's something that's going to benefit our profession as a whole. But probably the most impressive thing with Craig is that not only is he a researcher and an author, he has also been absolutely instrumental in getting oral medicine recognized as a specialty in the United States. We have tried for decades to get that recognition, and thanks to Craig, and I'm not just exaggerating, without Craig that would never have happened. So a personal thank you from me on that one, Craig.
Yeah, thank you, Michael.
Perry is a hospitalist, meaning Perry is a board-certified internal medicine from the University of Pennsylvania, where he also got his Master of Public Health. Where he did his medical school as well as his where he did his specialty in internal medicine. He got his MD, his doctor from Tulane University, and also a Master of Public Health from Tulane. At the present time, he works at Memorial Sloan Kettering Cancer Center in Manhattan. And the interesting part with Perry is that although until the COVID hit, his main focus was to treat cancer patients. And now he is treating cancer patient, but cancer patient with COVID. And I don't know if all of you know, but at 7:00 every night in New York City, everything stops and cars starts to honk their horns and people stand in the windows and clap and shout and so on and so forth. And the reason to do this are really for people like Perry, who are putting themselves on the front line, knowing the risk of what they're doing. It's like the front line in a war. They are the soldiers on the front line. And hundreds of physicians have contracted COVID, but they keep coming back. And Perry, it's fantastic what you guys are doing. And you have all my admiration for doing what you're doing, because you go back week after week and treat these patients at personal risk more than anything else. So thank you for that, and we're looking forward to your presentation about your clinical experience with these patients.
Thank you.
Before we give the floor to Craig, I just want to tell everybody in the audience that everybody appearing in this program is, we're doing it pro bono. We don't get any kind of honorarium. Yes, we have sponsors, but the sponsors' money goes to our production, which, by the way, is in the city of León, Guanajuato, in the center, the heart of Mexico. So without much ado, let's have Craig get the floor.
Thank you very much. If I can have the first slide brought up, and we can go ahead and get rolling. So I want to thank Jaime and Michael for inviting me. Good evening. It's a pleasure to be a part of this Genie in a Bottle series. And I'm Craig Miller, Professor in Chief of the Division of Oral Diagnosis and Oral Medicine at the University of Kentucky. Next slide, please. So my financial disclosures relevant to this course are shown here. Next slide. Participants are cautioned about using limited knowledge and fact check us before integrating new techniques into their practice. Also, the perspective I provide as a clinician scientist, as well as a practicing oral medicine practitioner and molecular virologist, come from over 35 years in the field. Thus, my perspectives may be slightly different from others or more granular than others who have different backgrounds and other perspectives. Next slide, please. The objectives of today's presentation are listed here. Each are covered during this short presentation. However, there's a lot of information, so the question and answer period will allow us to explore these topics at greater depth. Please realize the information regarding COVID is dynamic with changes almost daily. Thus, some of the information presented today may be outdated within weeks or months. Next slide, please. Viruses have been around for millennia. This 3,000-year-old hieroglyphic in the lower left panel depicts a pharaoh afflicted with polio, as seen by the red circle of the withered leg. So obviously, we've lived with viruses for millennia. What's the big deal? Well, transmission, infections, and epidemics are the big deal. This bar chart on the right shows that many of the epidemics and pandemics over the past century, note that virtually all of these are caused by RNA viruses, and that tens of thousands of people have been afflicted with these viruses for millennia, with the most notable being the Spanish flu being the biggest killer, and the deaths are shown in orange bars and cases in the blue bars. To the far right, you can see that COVID-19 is now one of the top 5 infections with over 16 million known cases and over 160,000 deaths. Next slide, please. There are more than 60 viruses known to infect humans. The RNA viruses are shown in the top panel of this illustration, with the DNA viruses shown at the bottom. Clearly, there's more RNA viruses than DNA viruses. As you may or may not know, RNA viruses are more likely to cause pandemics. Why? Well, there's 3 reasons that I'll present. First, they mutate easily because of RNA replication, and they lack a proofreading enzyme known as RNA-dependent RNA polymerase. Next slide. And they often spread easily by inhalation, and there are many respiratory viruses as listed here. And 3, they can appear quickly in secretions during the incubation period, often before symptoms appear, as exemplified by coronaviruses. Hence, they can be spread by asymptomatic, pre-symptomatic individuals before one knows it. Next slide, please. The pathogenesis of viral infection requires several progressive steps as the virus spreads through the infected animal. This process initiates at the portal of entry. Portals for respiratory viruses include your orifices, such as your eyes, nose, mouth, and respiratory tract. The inoculum can be inhaled air from infected persons who are talking, singing, coughing, or during close contact. Entry points for other viruses are through wounds, epithelial breaks, injections, or the anal genital tract. Blood is uniquely a portal of entry for mosquitoes. Next slide, please. With respiratory viruses, we know the infection involves inhalation of infectious droplets from contact of contaminated hands to the face. The average American has 1 to 2 respiratory viral infections per year and touches their face more than 20 times an hour. The highest prevalence of respiratory virus transmission occurs in congregate settings, in young children, and in persons around them. The blue circles show the infection may or may not lead to symptoms, a medical visit, hospitalization, critical care, and possibly death. Of note, infections in the elderly and immunosuppressed are more likely to progress, as well as those living in developed countries or regions with a high prevalence of elderly populations, such as Italy. Prevention and early resolution of the infection are our primary goals, but we remain challenged by viral infections such as coronaviruses because they can spread before symptoms appear. Next slide, please. How does COVID-19 compare epidemiologically with the flu? Well, let us look at a recent pandemic of flu, the swine flu. If you recall, there were much publicity about the 2009 swine flu pandemic, but less economic and social implications. Nevertheless, over 280,000 people died of this H1N1 influenza virus. So we should be well aware of the killing power of viruses. And next slide. Viruses such as COVID-19 have high infection rates as depicted by this bar graph. Being higher than the seasonal flu, if you compare it here, but similar COVID has to Ebola and SARS in its infectivity rate. Next slide, please. Let's talk coronaviruses. The Coronaviridae family are enveloped single-stranded positive sense RNA viruses grouped into 4 genera, alpha, beta, gamma, and delta. They primarily infect birds and mammals, including humans and bats, with bats serving as a reservoir of over 100 to thousands of additional coronaviruses. These RNA viruses are about 160 nanometers in size and consist of 30 kilobases strand of a positive strand sense RNA. And there are 7 known coronaviruses that infect humans, generally causing mild respiratory illness, such as the common cold. But coronaviruses are also known to cause enteric infections, mostly in infants and children, suggesting that fecal-oral contamination is another route of transmission. Next slide.
Craig, do you think we can go a little slower? I have a call from the translator to go just a little bit slower.
I can. I just wanted to try to get in under 15 minutes, but
don't worry. We'll give you all the time you need.
Okay. Coronaviruses have an outer phospholipid envelope containing spike glycoproteins or peplomers. These spikes bind to the host cell. In humans, COVID-19 utilizes the ACE2 or angiotensin converting enzyme 2 receptor, which is found on epithelial cells. Of note, ACE2 receptors are expressed in most organs with particularly high expression in the epithelia of the lung and the small intestine. The viral genome is coded and protected by the nucleocapsid. Once coronaviruses infect the host, they replicate silently for several days during the incubation phase. As viral titers build, virus appears in the naso-oropharynx, upper respiratory tract, and in the saliva, where they are expelled during expired breathing, coughing, and sneezing. Coronaviruses are most commonly associated with symptoms related to the common cold, pharyngitis, and pneumonia. Next slide, please. However, within the past 2 decades, 3 highly pathogenic coronaviruses have emerged. The first disruptive coronavirus was SARS. It emerged during the winter of 2002 and caused more than 8,000 infections and almost 800 deaths. SARS is a zoonotic infection transmitted from bats to other mammals before infecting humans. It causes fever, cough, shortness of breath, and disrupts lung epithelium, leading to viral pneumonia. After 2003, there have been no reports of additional cases of SARS. Next slide, please. Another coronavirus jumped from animals to humans in 2012 to cause MERS, or Middle East Respiratory Syndrome. MERS spread throughout Europe, but unlike SARS, which was only a 9-month outbreak, MERS continued to smolder, next slide, due to sporadic transmission from camels to people and limited chains of person-to-person transmission. The features of MERS include coughing, fever, shortness of breath, respiratory illness, fatal pneumonia, and acute respiratory distress. To date, MERS has killed about 800 people. Next slide. COVID-19, or novel coronavirus, also known as SARS-CoV-2, is the 3rd outbreak of severe respiratory disease caused by coronaviruses transmitted from animals to humans. This virus arose in Wuhan, China in November 2019, hence the name COVID-19, and it has rapidly spread to infect more than 16 million people and cause an ongoing global public health emergency. Next slide, please. COVID-19 contains a single-stranded, 5-capped, positive strand RNA.
Greg, can you slow down? Can you have one more slide, please? So you're 1 slide behind here, I think. Let's go 1 more slide.
Okay, thank you for catching up there, Michael. So COVID is a single-stranded, 5-cap, positive strand, short RNA molecule that synthesizes its protein that are needed for its progeny. There are at least 6 open reading frames that encode several proteins known as the spike protein, endoribonuclease, helicase, replicase, and proteases. The spike protein, shown on the far right side, or S protein, emanates outward from the virus membrane and plays a crucial role in mediating entry into the host cell. Each spike protein is built as a trimer, each containing a receptor binding domain. Next slide, please. Once the S proteins attach, as shown on the top left, they are then cleaved and activated by a host cell surface protease known as TMPRSS2. Virions then enter the endosome, and they're encased, but the S protein catalyzes fusion of the virus in the cell lysosomal membrane. And this fusion allows the viral RNA to be released, and as you see in the lower left, transcribed and translated into viral polyproteins that allows for the production of viral progeny, which are baby viruses. These mature in the endoplasmic reticulum shown in the lower right panel, and then they spread upward and mature and eventually fuse and egress from the host cell. Next slide, please. Steps in the infection are dictated by several factors, including the amount and concentration of the inoculum, where the virus enters, how well the virus can replicate and evade the mounting immune response. That involves several steps that we will talk about that lead to cell damage, cell lysis, and ensuing inflammation and cell-to-cell spread of new viral progeny. Of note, the amount of inflammation and cytokines produced can lead to altered immune responses that then favor bacterial superinfections. Next slide, please. The symptoms of COVID-19 may appear anywhere from 2 to 14 days after exposure. However, the incubation period may be up to 30 days. The symptoms are generally mild in 80% of those infected and can be asymptomatic, especially in children. The usual symptoms are fever, sore throat, cough, fatigue, shortness of breath, chills, myalgia, headache, dizziness, loss of taste and smell, and even, as shown in the right corner, oral lesions like oral ulcers. Next slide, please. A question of interest is, why do some viral infections progress and result in more morbidity than others? For example, some persons experience only minimal or mild disease, and other persons progress and succumb to the disease. Why is that? Next slide, please. There are 7 major factors that regulate acute viral disease progression. Let's examine each of these at least briefly. Next slide, please. First is the inoculum size, which can be large or small depending on how the virus is delivered. For example, from a handshake versus a sneeze, or a person you talk with briefly versus spending an hour sitting next to an infected person at a dinner table. Higher inoculums contribute to increased likelihood of infection taking hold and progressing. Next slide, please. Viruses replicate based on site of entry. For example, a virus that lands in your nose will display a different replication pattern than a virus that lands in your lungs. As you remember, next slide, please. The lungs have very high expression of the human ACE2 receptors. So that site favors entry and increased viral infectivity and pathogenesis versus sites in the upper respiratory tract or mouth. How does the virus get from the nose to the lungs? Current evidence suggests that the virus may arrive in the lungs in nasal secretions that are swallowed. Hence, it is possible that something like decongestants, if used early during the early phase of infection, might actually limit the spread of COVID-19. Next slide, please. The viral strain or variant is generally not discussed much with respect to COVID-19. However, there are several variants that exist. This figure on the right shows that the early variants, shown as blue dots or blue circles, began in Asia and experienced genetic changes as the virus spread to Europe and the Americas. While some mutations don't alter the proteins made, other mutations can contribute to differences in viral transmission, spread, replication efficiency, and shielding from the immune system. Thus, some patients may become infected with a viral strain or variant that is more pathogenic than others. Next slide, please. Recently, the D614G variant of COVID-19 has been identified to be a highly circulating strain that has higher infectivity in cell culture than other variants. Whether this translates to in vivo, that is in humans, is not yet known. However, it is clear that viruses can enter more efficient and can hijack the host cell more efficiently, would provide distinct advantages for a COVID-19 infection. Next slide, please. Thus, the progression of the infection is really a race between steps 1 through 6, next slide, and step 7. Next slide, please. So it's a race between 1 through 6 and step 7. Let's go into a little detail here. Step 7 involves the host recognition and the immune response. Next slide, please. Numerous RNA and DNA viruses inhibit cellular gene expression by directly targeting mRNAs in order to redirect resources from viral gene expression and dampen the innate immune responses. In coronaviruses, this host shutoff activity is best characterized for a protein known as NSP1, which inhibits host translation and interferon production. Coronaviruses, like other viruses, RNA viruses, dampen and subvert the host immune response. Next slide, please. Generally, viruses do this by inhibiting the expression of viral proteins that are cut and placed on the surface and displayed on the major histocompatibility complex. This process that the virus subverts hides the infected cell from the immune system. Next slide. And if the infected cell is not seen by the immune system, and if it's not seen by the cytotoxic T lymphocytes, the CTLs, then the CTLs cannot destroy the virus-infected cells. Next slide, please. Other antiviral mechanisms also are used by the host to eliminate viral infections. However, COVID strongly downregulates the production of interferon beta. Hence, 3 interferon-related mechanisms or processes shown in the yellow boxes at the bottom there are subverted by the virus. Of note, the ability of COVID-19 is more than 10 times more potent or more efficient in downregulating these processes than a normally circulating human coronavirus strain that causes the common cold. Next slide, please. Coronaviruses, like many other viruses, target the JAK-STAT pathway. As you can see with the red coronavirus there, it's targeting a protein, it's NSP1, induces degradation of interferon beta RNA during host shutoff, and it makes another protein known as ORF6 that inhibits STAT1, which is necessary for the production of interferon. Next slide, please. Thus, the immune system is slow. Neutralizing antibodies do not arrive for 1 to 2 weeks, and many infected cells die. And this all leads to the next slide. Increased inflammatory monocytes, macrophages, next slide, please, and neutrophil accumulation in the lungs, and marked elevation of pro-inflammatory cytokines and chemokines. Next slide, please. So, we can summarize why do some infections progress and others do not with this table. There are 7 main factors determining the outcome of the infection, and I've only provided minor insight into the immune system response, which obviously is altered in the elderly, immune suppressed, and diabetic. Nevertheless, the table shows across the top margin that the viral or human response can be either low, moderate, or high efficiency for each one of these categories. Next slide, we'll fill in the table here. For a typical garden variety coronavirus infection that causes the common cold in a healthy human, otherwise healthy human, the inoculum, entry site, number of receptors, virus strain, replication efficiency, and spread are all of low efficiency, and they're not sufficient to overcome the usual immune response, and the infection does not progress. Next slide. However, if the factors favor the virus a little bit more and the immune system a little bit less, then progression is increased. And as we move from left to right, when the virus has greater advantages over the immune system and becomes much more efficient, which occurs in the elderly or someone that has comorbid conditions such as gross obesity, diabetes, immune suppression, or a predisposition to blood clotting, then progression can be quite severe. So with that, I will conclude this presentation by recognizing the difficulty the United States and the world's having with the spread of COVID-19. However, we can help by being kind and considerate, by social distancing, by wearing a mask when in close proximity to others, and by washing our hands and following appropriate infection control measures. Thank you very much. Hopefully I didn't go too long.
Wow, that was very impressive. I really hope that the translator could translate most of what you said there, Craig. But anyone who wants to look at this again, obviously, is going to be on YouTube later on. If you want to review this again, because I think what Craig did gave us some very, very, very important information there.
Yeah, well, I have, I don't know the audience, but I have a lot of questions. But we're going to go to another video of our sponsors. And I want to use this opportunity to thank our sponsors, Colgate-Palmolive Mexico and Ideas Dentales, for helping us support the production of Genie in a Bottle. So let's go to a short video and we'll come back.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorhexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. No contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorhexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada Colgate PerioGuard con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Okay. Well, as Michael said, if people thought it was too fast, they can always go back. After we finish the program, it's going to be on IDA Academia YouTube and Facebook lectures in English. And you can see it again in IDA Academia Facebook Live in Spanish. So, Michael, why don't you introduce Perry, please?
So, yes, so Perry Dubin, he is a doctor in Memorial Sloan Kettering, internal medicine, usually takes care of cancer patients and has now been responsible for the cancer patients that actually come in with COVID-19 as well. And he's going to give us some of his experience treating a couple of cases. So Perry, thank you very much for joining us and very much looking forward to hearing what you have to say.
Thank you all for inviting me. So I'll begin. So again, my name is Perry. I'm an assistant attending at Memorial Sloan Kettering, which is a cancer center, and have a teaching affiliation with Weill Cornell Medical Center. Next slide, please. I have no conflicts of interest to disclose. I just of note, as Michael was saying, I do work at a cancer center. So I only work on inpatient patients. So what I'm going to be displaying to everybody is my personal experience with cancer patients who have had COVID. Next slide, please. So my objectives are to briefly review 3 cases at 3 different outcomes and then provide any opportunity for any questions you may have. Next slide, please. So first off, because COVID is a respiratory illness, a lot of what I'm going to be discussing is the oxygen requirements that our patients had. So on the left of your screen, I believe it is, at least it is for me, there's nasal cannula. This is what you would traditionally associate with somebody who needs a little bit of oxygen. Usually think about someone with COPD or other lung illnesses. They usually just carry around a tank, or nowadays you can carry something that's smaller that's in there that you can put over your shoulder. But that's the basic nasal cannula. And the total amount of extra oxygen provided is about 25 to 60%. Our normal oxygen levels in the air is air getting about 20%. And so the nasal cannula gives you an extra boost, but it's not too much. If you, and on the left, you can see I see LNC means liters nasal cannula. And again, usually what we give with this nasal cannula is 1 to 6 liters, but you can go higher in emergencies. But the LNC or NC or L, that might be next to any type of oxygen, a description of the amount of oxygen given is a reference to how much oxygen needs to be given. If the nasal cannula is not enough, the next step is either a face mask or what is available at my hospital is called a non-rebreather. And that can provide 80 to 100% oxygen depending on how good the seal is. But for a patient who needs excessive support, there's the breathing tube with the ventilatory support, which you can see on the right. You can give up to 100% oxygen, but with ventilation, you also are able to control some more of the respiratory dynamics along with the pressure that you give to the patient. In general, a goal blood oxygen level in a hospitalized patient is above 92%, but you can probably get away with above 90. Next slide, please. So case one is Mrs. Y. She is a 60-year-old female with remote history of thyroid and breast cancer. Currently no evidence of disease for several years. Who presented to initially an outside clinic on March 22nd for cough and fevers. At that time at the outside clinic, she was found to be COVID positive. She was initially doing well, just had cough and fevers, was sent home to self-quarantine and treat herself symptomatically with a Tylenol and ibuprofen, or acetaminophen and ibuprofen. Over the next 6 days, she continued to have fevers up to 101 reported at home, had dry cough and diarrhea. But it was on the 6th or 7th, on the 8th day, on March 30th, she presented to my hospital's ER for worsening described shortness of breath. However, when she came into the ER, her initial vitals showed that she was afebrile at that time. Her pulse was normal, 66. Her blood pressure was 105 over 63, which could be low for some people, but for her it was normal. And she was breathing, her respiratory rate was 20. The one thing though is her blood oxygen level was 93% on room air. And like I said on the last slide is that your goal is to be above 90% or 92%. For her, 93% of room air was actually a little bit on the lower side. For a normal person like me who has no lung disease, my blood oxygen level would be expected to be above 96%, although you don't need supplementation at this level of 93%. Next slide, please. This is an example of her X-ray. You can see she's actually a pretty thin woman, and so you can see the white. I don't know how familiar everyone is with X-rays, but you can see kind of the whiteness in the lung portion, and you can see that there's a kind of a patchiness to it that is very consistent with a COVID pneumonia, and it's present on both sides throughout the lung. Next slide, please. So her hospital course, soon within hours after being in the ER that we have, she developed fever and an oxygen need. Remember she was on room air initially, no oxygen supplementation, and then she suddenly developed a temperature to almost 103. Her respiratory rate went up to 40, and for those who don't know, a normal respiratory rate is usually between 12 to 20. Her blood oxygen, continued to dip down below 92% to the point where she needed to be given up to 3 liters nasal cannula to stay above 92%. So she was 93% on 3 liters. And then, interestingly, over the next 36 hours, her breathing rate increased and her oxygen requirements required a non-rebreather. That's the mask that I mentioned before, to be at a safe level. On the morning of April 1st, she was taken to the ICU for higher monitoring and to receive the highest level of oxygen without a breathing tube. She remained in the hospital for weeks after due to the high oxygen requirement, and she was very tenuous. If she would just walk a little bit, her oxygen would drop on the highest level of what would be a home safe oxygen. And it took several weeks before we were able to discharge her, and she required home oxygen. Next slide, please. A couple things that I thought were very classic about this case, or at least what we were seeing, is that it seems that COVID patients on the day 7 to 10 very often have an acute decompensation around that period, 7 to 10 day after presenting symptoms. And she did that in about day 8. Many people will need oxygen support at home for weeks or months after recovering from COVID. Is something that we're seeing more and more. There is some level of permanent lung damage that not all, but some patients are experiencing. Next slide. Thank you. Next case is Mrs. B. She was a 46-year-old female with history of advanced lung cancer with many complications. Her lung cancer was significant for fluid around her lungs, spread into her lungs, within her lungs and within the lymphatic drainage of her lungs as well. She was seen in the emergency room on March 13th for fevers and body aches, but she was actively undergoing chemotherapy, and they attributed it to that point, those symptoms, to the chemotherapy she was getting. Interestingly, we did not have COVID tests available. March 13th was right before the entire city shut down, before we were, adequately prepared for what was about to happen. She actually even received another cycle of her chemotherapy on March 20th, a week after that. And around then, on March 20th or 21st, she was started on home oxygen for worsening dyspnea. Dyspnea is a medical term for shortness of breath. That was thought due to her underlying lung disease that I had previously mentioned. She also even had a chest tube placed to help with the drainage of the fluid around her lungs, because at our hospital, we're able to manage some of these things as an outpatient. She then re-presented to our ER on March 27th. That's 2 weeks after her initial presentation for fevers and body aches, with worsening fevers, chills, and diarrhea for 2 days. At that point, she was able to get a COVID test, and it showed positive. Next slide, please. Maybe might be a little hard to see this. It's a little blurry on my screen. But this is a vital signs trend, and you can see the green arrow. This is respiratory rate, and the initial admission date was, I believe, March 23rd. And then what you're seeing is over the next 18 to 24 hours, or 36 hours, of her progression. So in the beginning, her respiratory rate when she initially came in was in the 20s. And then you can see that towards the end of this, her respiratory rate got up to the 40s, again, very high. Her blood oxygen level, it's hard, I don't know how hard it is for you all to see, but for me, it's a little difficult to see. But what you're seeing is that the nasal cannula level in the yellow line goes up to 6, and then eventually required non-rebreather to keep her oxygen level up into the 90s. So by about 18 to 36 hours afterwards, her oxygen saturation dropped down to 79%, and she would need a non-rebreather to be placed. That is the face mask I mentioned before. Next slide, please. So this was a pretty sad case. She's a younger woman in her early 40s, had some children, but she remained a non-rebreather for about a week and a half before ultimately dying on April 3rd. She was on comfort care measures only at death. She had pretty advanced lung cancer at baseline, and was only had a life expectancy of 4 to 8 weeks. And after multiple discussions with her, and with her deciding as well, the decision was realized that to do something like intubating her, putting her on a breathing tube would be more harmful than helpful, because her likelihood of ever coming off of the breathing tube was very small. And she chose not to undergo that. Next slide, please. And this is kind of similar to what I showed before. For our hospital patients, you have, with COVID-19, they can go from absolutely no oxygen or minimal oxygen, just 1-2 liters nasal cannula, to non-rebreather or needing intubation quite rapidly. Next slide, please. And the third case that I had that I'm explaining is Mr. R. So he is a 60-year-old man with a history of locally advanced breast cancer with recent mastectomy, and now on maintenance chemotherapy. So he does have active cancer, but he's recently been treated and it is stable. He was diagnosed COVID positive at an outside urgent care, which is just an outside clinic that we have in our in the New York City area, on March 19th. And then about 7 days later, he presented with worsening fevers worsening fevers over the past 7 days, up to 102, 103, cough, shortness of breath, and body aches. The main reason for presenting to the emergency room was, though, he had a home blood oxygen monitor called a pulse oximeter, which showed a blood oxygen of 86 to 93%. And like I said, above 90% is what you want your oxygen level to be. Next slide, please. As you can see, his x-rays here on the left side of the screen for me is you can see that he has, this is when he was first admitted. He has some patchiness similar to the one before, to the previous x-ray, maybe not as bad. And he was actually prepared for discharge on home oxygen because he had been stable for several days on 1 to 3 liters nasal cannula. But then on April 2nd, right as we were getting ready to discharge him, he suddenly became short of breath. His oxygen level dropped. And repeat x-ray at that time showed that, and which is on the right of the screen, which showed that he had worsening signs on his chest x-ray and worsening pneumonia. Next slide, please. So he quickly recovered from that moment. It took less than a day for his oxygen to stabilize back to 2 to 3 liters nasal cannula. But he was very tenuous, and any amount of movement causes oxygen levels to drop. And it wasn't until day 28, which was about 4 weeks of him being of him having symptoms, that he was able to be discharged on a steady level of home oxygen of only 1 to 2 liters nasal cannula. And again, he was discharged on home oxygen. Next slide. And then this is similar to the takeaway of the other two, is that there is a significant damage that is done to people's lungs with COVID, and they can all require to have an oxygen need, and we're not sure how long that will last for people, and we're still waiting to find out. And I believe that is my last slide. So thank you all.
Great. Thank you very much, Perry. It's always interesting to hear someone's personal experience as a physician rather than reading stuff from a textbook and so on and so forth. And thank you for the explanation. It seems like the oxygen level was the focus here and how people can remain on it. But what really I took home from this was that in all of these cases, the patients that survived, they keep having problems after they sort of recover from COVID. Now, you talk about cancer patients, but even non-cancer patients, it seems like many patients continue to have tremendous morbidity for months, sometimes for months after they have sort of recovered. Is that correct?
Yeah, there are many reports of normal patients with no underlying medical disease who either die from it or have long standing oxygen requirements. Our patients are at very high risk for developing lung complications, as Dr. Miller was saying. If you don't have a good immune response, the virus is going to go rampant and it's going to be able to do more damage to your lung cells. So our patients who are getting chemotherapy are obviously not able to protect their lungs as well as a normal person. So they're going to be at higher risk for worsening outcomes.
Yeah.
Perry, you just took me in 15 minutes through 10 seasons of Chicago Med. It's like, this is real. It's not TV, but I'm really impressed with what you do, and I think we have a lot of things to discuss about. And there is a special mention for Craig that somebody just saw you or heard you in a presentation on the American Academy of Oral Medicine. Is that right? Correct.
That is correct. I gave a short presentation, maybe a little bit slower. I apologize to everybody that I went so fast. I was under the rubric that I needed to get that in 15 minutes. And as Michael told me in advance, I probably had too many slides. So I apologize to everybody for doing that. But there was a message that I wanted to send that was, there's this viral component and the immune component. It's really hard to cover both in just 15 minutes. Maybe you can cover the virus in 15 minutes and maybe you can do the immune system in 15 minutes, but to do both was probably a very tall task. So again, I'll apologize. But yes, I spoke last week on specialty recognition to the American Academy of Oral Medicine had their annual meeting postponed in April so they decided to do a virtual meeting and asked me to give the history behind that. So shout out to everybody that saw me recently. So it's my pleasure to do that. I also wanted to kind of weigh in, if I might. I wanted to thank Perry for sharing his personal experiences with the patients that he has managed, and mention in addition to the long complications these patients have, they obviously can have complications of other organ systems or tissue systems too. There's complaints of hearing, taste loss and smell loss. Taste and smell loss that can persist for weeks and maybe months and maybe for years. We don't really know yet, as well as fatigue. A lot of viral infections can cause fatigue. The classic virus for many years was Epstein-Barr virus, causing or being associated with chronic fatigue syndrome, and it's a difficult management scenario when a patient comes in to a physician with the complaint of fatigue. Which is probably a whole nother topic, but just wanted to point out that a lot of people who walk around think that COVID is either not real or it won't affect me. Even if you do have minor symptoms or minor complications, if you lose your ability to taste, which a lot of people might say is a minor complication, but you love certain flavors, now you wouldn't have that capacity for many weeks or months possibly.
Now, Craig, can I ask you a question?
Sure.
Now, let's say if I understood, the COVID goes through the eyes, nose, and mouth. But you say that it gets to the lungs when we swallow it. So not when we aspirate it?
Well, it is, when nasal secretions can come down the respiratory tract. Okay, so they're going to be going down that direction, down the nasopharynx. You swallow, things are going to go into the stomach. So, the things are moving in separate pathways there. So, yes, the point being is, and I don't know if swallowing is the best word, but basically you do have saliva that you swallow every day that contributes to buffering capacity in the GI system that a lot of physicians don't think about when patients come in with a burning sensation in their throat and have GERD. Oftentimes those patients actually can have a salivary dysfunction, a low salivary flow. So that's sort of wandering into a new area. I don't think physicians get much on saliva when we, in medical school, the focus, maybe they'll get one lecture and that's it. I don't know, Perry could comment more on that, but certainly you could inhale the virus and it could go that way. It could inhale and land on nasopharynx and replicate cell to cell and slowly spread down the nasopharynx and make its way down. And that's one reason why there's a delay. You don't develop symptoms the next day. And the other possibility is that infected cells break off and then they travel down the respiratory tract and then they land and then they'll replicate there.
Now, let's say you touched something, but how many? Is there a way to know how many? If you breathe in one virus, or do they come in clusters of virus? Are they one per droplet, or does somebody know this? Maybe I'm asking questions that there are no answers. So just tell me. I don't know, and it hasn't been.
No, they're very good questions. A sneeze or a droplet can contain thousands of virions. Okay, so as opposed to when you talk and you aerosotize, then you're more likely to have individual virions sort of floating around. And viruses don't like to float around by themselves. They like to be attached to things. So they like to be attached to epithelial cells. So their preference is...
I just want to follow the track. So let's say somebody sneeze, you got them you aspirate it, they stayed in your pharynx. They have to attach to something in order to replicate, right? They have to find the right protein, connect with that cell, get into the cell, and then starts to replicate?
Correct.
Okay. So then you have a lot of viruses going into a lot of cells and replicating again. Now, we hear from patients that they were told that they didn't have any symptoms because it was probably a low charge of or low amount of virus, because all the viruses are the same. They have the same. They share the same potential of getting somebody sick and kill him, right? So it's the amount in what they replicate what makes the difference in people that may or may not have, or it has to do straight with the immune system, because we see patients with cancer who recover in chemotherapy that in my vision, they have their immune system completely down or partly down, and they do survive the COVID and eventually, hopefully, the cancer as well. And other people who are healthy with no comorbidities or not known, now that we start to see a lot of young people who get sick. In a very few days, they have this need for oxygen. They cannot breathe, and they go into either the mask or the tube, the respirator. So, is it only the immune system? Is it the amount of virus that can replicate? What is in your mind, or also you, Perry, that you see all these things happening all the time? What does it make a difference? Why me? Why other people don't? Or why they and not me? Do we know?
Would you like for me to answer first, Perry, or do you want to go ahead?
I mean, I think it's more of a virologic perspective. But
okay, I'll start, and then Perry can weigh in. That what I was trying to explain in those slides that we're going through pretty rapidly was that there's a host and a virus race. The virus is going to try to get in the cell, replicate, produce progeny, turn off all the cell mechanisms to say, hey, I'm infected, because a virus, when it's infected, chops up the virus and puts little pieces of it on the surface and it waves them like a flag and say, I'm infected, I'm infected, I'm infected. And so then the immune system recognizes it. But the virus is also blocks the display of those, so it becomes a race on how well or how efficient the virus is in blocking the display and turning off interferons as a step before the recognition of the immune system. Now, the immune system has multiple arms. You have the innate immune system, you have the cell-mediated, and you have the antibody-mediated. We didn't go into great detail into that, and this is where I'm going to toss it to Perry to say, well, there's some evidence out there that using neutralizing antibodies has some benefit in some patients, and Perry can share their experience and when they use it and how often they have it. But, that's one arm of the three in the immune system. So when you say someone's immune suppressed, maybe they have one arm suppressed, maybe they have two arms suppressed, maybe all three arms are suppressed. Not everybody's suppressed equally. And I'll toss it to Perry to sort of weigh in.
So yeah, we are using, by the end, actually in March, we didn't have anything, but towards April, May, when I was caring for COVID patients, we were using the neutralizing antibodies of convalescent plasma, which is when patients who've recovered from it would donate their blood and it would be purified to just get the antibodies that existed from COVID in order to give to the patient. I don't know if we don't have any actual data yet that's been published on how useful it's been. But that is something that we were giving our patients. I think it's important to realize that, like what Dr. Craig Miller is saying, is that if myself and Jaime are standing in the exact same room, have the exact same cough or sneeze on us. We're both going to have different responses to the amount, even if we have the same number of virus that's given to us. I myself am a younger person. I believe I have a good immune system. I don't have anything that should suppress it, but who knows? But Jaime, you're older than me. You might have other medical complications. And so for that reason, it's different for everybody. There also are some genetic components where there might be some people who are predisposed to having worse outcomes to either this virus or viruses in general that we weren't previously aware of or that we're still discovering. There's no specific answer for why each person has a specific response to the virus, but I think that it's understanding that I think that race is a great analogy, is which is going to be stronger and what's going to be better. It's being shown that wearing masks are great at decreasing the amount of the viral particles that are in the air, and also breathing in fewer of those particles as well, which is just another reason why masks are so helpful at not just decreasing spread, but decreasing mortality, I believe, on the virus itself. I hope that's helpful, but I wish that we could tell everybody this is what's going to happen if you get the virus, but I don't think that answer will ever exist.
Okay, Michael, hold on. We have to see a very, very short video, Michael, and we'll be right back. Don't go away.
Radicalmente efectivo es O Radical. No te dejes llevar por opciones que solo buscan venderte aplicadores, dosificadores y líquidos que no conoces su origen. Independientemente de la forma en la que lo apliques, lo que necesitas es un sanitizante que elimine todas las posibilidades de contagio en tu casa o negocio. O Radical es un potente sanitizante elaborado por nuestros laboratorios. Por su composición no es dañino, ya que es orgánico y se puede usar en la piel o en cualquier otra superficie que haga contacto contigo. Radicalmente efectivo es O Radical.
Okay, I got 2 questions here from the audience. One for Perry and one for Craig. So Perry, is it true that a disease causes blood clots in many different organs? That's for you. And Craig, for you, is what do you think the reason is why some patients produce neutralizing antibodies or even antibodies or maybe not antibodies at all? And if you can talk a little bit more about these antibodies, are they neutralizing or for a long time, could they actually work, meaning could you be reinfected? So Perry, the blood clots and then antibodies and reinfection for you, Craig.
Absolutely. So I've focused mostly on the most common symptoms that we're seeing, which are the lung symptoms. But for whatever reason, and we think it mostly has to do with just the high level of inflammation that this virus causes amongst human beings, is that it causes you to be at risk for blood clots. And that includes strokes, heart attacks, but also a lot of blood clots in your legs and those types of blood clots that can travel up to your lungs, called pulmonary emboli. That is a big fear with our patients. And it's become common practice that anybody with COVID is on high risk blood clot prophylaxis with certain medications when they come in. And if you ever have an oxygen requirement, it's actually our hematology department's recommendation that you are discharged from the hospital on blood thinners for a month because of that high risk. As you may be aware, H2 receptors are in every single organ system that we have, and there are a lot of complications throughout the body. We're seeing complications. A lot of people are needing dialysis who have very bad disease. There's some evidence that there's neurologic involvement, although how much of an effect that has on the brain is not entirely clear. But it can affect every single organ system, and blood vessels and the clotting system are one of those organ systems that are being affected.
Thank you, Perry. I would also like to comment that I've read that the human ACE2 receptor is also present on vascular endothelium. And so that may be one of the reasons some patients are a little more susceptible to blood clots. Are you seeing blood clots in patients that were already on anticoagulants or already had a blood clot in the past, or does this just seem to come out of the blue?
So this is something that was slowly being recognized, and I have friends who I actually never experienced a patient with a blood clot, but I have friends who are ICU doctors in New York City who, we're all texting with each other when it was in mid-March when no one really knew how to treat anything. And like, that was like anecdotal reports that were being told. It was like these young 25-year-olds who would have COVID would come in with respiratory compromise, and they'd find out it wasn't just the COVID, they'd have a large blood clot and no medical history. So it is something that is definitely being seen, and why some people get it over others is unclear, but it is something that we're seeing and treating for more and more. My patients, who a lot of them are on blood thinners at baseline, might be why I never saw it. Thank you. So with respect to the questions I received about neutralizing antibodies, again, my opinion may be slightly different than a physician's opinion, but let's just talk about antibodies and neutralizing antibodies. The word neutralizing in front of the word antibody, by definition, means that the antibody will bind to its target, in this case, a virus, in this case, COVID-19, and it will neutralize it. It's not a neutralizing antibody if it can't neutralize it. So it would just be an antibody against COVID-19. So when you say it's neutralizing it, it will bind to it. It will then attract complement and other things to pull the virus down into the immune system and eliminate it. There's always a question of, well, how much do you need in order for that to work? And so that's always a great question, because the classic example is if you go in and you get a vaccine to hepatitis B, 10 years later, they say, oh, you don't have any neutralizing antibodies. Your titers are so low that, maybe you need a booster, maybe you don't. And, this whole thing needs to take a step back and say, well, you have B cells, you have memory B cells. That's the whole point of a memory B cell, is when it sees a viral antigen, it will trigger the production of antibodies. So just because you don't have circulating antibodies at a level that most people consider is above some threshold, doesn't mean you won't produce neutralizing antibodies when you're exposed to that. So there hasn't been a lot said that where that threshold line is. Maybe for Michael, his threshold line might be very low because he's healthy in many other respects. Maybe I have an immune disorder, and so maybe my neutralizing antibody levels need to be a little bit higher than Michael's. And so you can't just go across and tell everybody that, oh, you need to be above 200, or you need to be above 100 or something. It's going to matter from a variety of other perspectives. But the whole definition of neutralizing antibodies is that they do neutralize, they do protect. And in my opinion, although I think I've heard on the news many times they don't know whether neutralizing antibodies work, there has been cases, I know when plasma is given and it contains neutralizing antibodies, there's case by cases where it works. I haven't heard many reports where it doesn't work very well. So maybe it's not working and those don't get reported because negative studies tend not to get published. And so I'm not really sure. Maybe Perry could give us an idea just in his own experience, when you've given or you've seen neutralizing antibodies given, can you give us a ratio of what response rate there is? Is it 100% respond? Is it 50% respond? Do you have enough cases that you could even comment on that? I don't have enough to say whether it does or does not work. We got to a point where we were giving every single patient. It wasn't the studies that are being run are really just safety studies. They're not actually randomized control trials where you're giving placebo versus the convalescent plasma. Also, a problem with the convalescent plasma is that you're not actually controlling for the amount of neutralizing antibody that you have. So I can't really say for sure. I know that my ID department doesn't think they made much of a difference, but again, we don't have actual empirical data. That's more of an anecdotal word that I was hearing.
So thank you, Perry. One of the things to be considered is going back to Jaime's question. Well, what's the factors that really matter? Well, if you give neutralizing antibody to a patient who's stage 4 cancer, who's not expected to live, and the neutralizing antibodies don't allow that patient to survive, was it because the neutralizing antibodies didn't work, or that patient was just not going to survive no matter what you gave them? So there's so many factors that play a role in when do you give them. How much viral load? Nobody's talking about viral loads, but with HIV, we talk about viral loads all the time. And so we're not really talking viral loads. Is anybody talking viral loads, Perry? And like, if this patient's viral load is this high, then they get remdesivir or something like that. Has it moved to that stage yet?
I think that it's more about clinical. It makes lots of sense for an antiviral to be dependent on the viral load. Because also a lot of these patients, and something that I didn't get into, it's that there's a question of whether it's the virus causing the injury or whether it's the immune response causing the injury. But right now, the remdesivir and any treatment that we have on hand, at least at Sloan, is all being decided based off of clinical outcome or the clinical condition at that moment. It's really about oxygen level or other symptoms.
Don't forget, when we talk about viral load, we talk about the virus in the blood. And here, the samples of virus, we don't take it from the blood. We take it from secretions. So we take swabs and so on and so forth. So it's going to be very hard to figure out the viral load because, as you know, some of the tests comes back negative because we didn't get enough virus in our swab. So viral load, I think it's something we have to look for in the blood later on. There's one more.
Michael, could I weigh in one thing on that? So, my preference is to base as much diagnostic information on both clinical imaging as well as biological data. And so we're not there yet with COVID. But with many other diseases, we are into the biological realm. So Perry certainly knows this when it comes to cancer management now, or you're getting genomic sequences and matching up drugs and things like that. But COVID hasn't evolved yet to the biology. As Perry very well said, it's pretty much on the clinical management. What's their oxygen sat, and how, what's their image look like of their lungs, and what's their fever and some other symptoms, and he could better say than I. But I'm looking forward to when we move a little bit more and start introducing a little more biological information to help in the decision making, because I think it will help.
Yeah. There was one more question here, and it was about the correlation between blood type and COVID-19. Perry, can you speak to that?
So it seems like there are some genomic studies that shows that people with a type A blood are at higher risk for worse outcomes, and type O are more protected. It seems like type A at baseline is you're at risk for any type of your immune system is considered overactive at baseline, and you might be more at risk for bad outcomes with any type of viral infection. And I think what's important also to realize about COVID is that at the end of the day, it is a respiratory illness. Any respiratory illness can have pretty severe outcomes depending on your clinical status, like the flu. It's much worse than obviously the normal one, but I think what we're seeing is that all our eyes are looking at the complications of COVID-19. And I think this is going to actually, move the field of virology leaps and leaps forward when people are realizing, it's unlikely that, blood clots are something that only happen with COVID-19. I would not be surprised in the future if we find out that, there actually is an increase with normal coronavirus that we weren't aware of. Not normal, but the less virulent types. But to answer your question, Michael, there's I believe there maybe Craig will know more, but I believe there's actually some question about the validity of that study recently about type A having worse outcomes or not.
Does that have to do that most African Americans are type A, and those were also hit very hardly by the disease?
Don't know. I don't know enough information about that. I think there are a lot of socioeconomic factors about why people of color are having worsening cases and mortality. And I think a lot of that's about how, systematically the society, at least in America, has led to a lot of essential work being supplied by people of color. And because of that, they're more prone to get the illness themselves. And then systemic racism that exists within the medical system, and at least here in America, that probably leads to worse outcomes, along with socioeconomic factors that lead to higher comorbidities. So when it comes to race, I can't say whether they have more type A blood, but I can say that it's. I think that majority of the increased morbidity and mortality has been secondary to socioeconomic factors.
You left out AB. I'm AB. You mentioned A, O, and B, but you didn't mention AB.
I think it's the allele of having type A. That type A allele is actually it creates either, I actually don't remember whether it decreases your immune response, allowing the virus to get stronger, is what's postulated, or whether it's that you're one of those people, like I briefly commented on before, that has an overactive response that leads to bad outcomes.
And positive and negative, those have nothing to do with
the antibody. Yeah, the Rho antigen is not significant. It's A and O.
Michael, you mentioned in one of our conversations that it was the same to have a very bad or low or diminished immune system, or to have a hyperreactive immune system. Remember?
Yes.
So is that?
We talked at that time. There were a couple of of programs ago. I talked about the cytokine storms that we see, and I think Craig sort of alluded to it, and Perry has alluded to it as well. When you have this overactive immune system that causes all this destruction, and at that time, if I recall correctly, we talked about pediatrics specifically that had this tremendous cytokine storms and how they overreacted to this virus. I don't know if any one of you guys want to comment on that.
We're going to do it right when we come back from the next video. It's a very, very short video, and it's just to inform our audience that can you run the video, please? Lower the music. All our lectures are free. All our videos are free. The music is too loud. Okay. Yeah, all our videos can be found either in Facebook Live, ID Academia, or in YouTube Live. They're free. You don't have to pay for them. Everything is free and it's available. It's almost, March, April, May, June, July. It's 5 months already that we're doing this in a weekly basis, sometimes twice a week. And you can find all the information in either YouTube or Facebook. And it's also a good time to say thank you to our production in Mexico City, to everybody there that it's, they're loading me with the questions. We haven't even got the questions from the audience. Thank you to Blanca, to Miriam, to Erin, to Santos, and to Maria, and all the guys in Grupo Produce in Leon. But I still have questions. So you wanted to comment something, Michael. Sorry.
No, there was a matter if Perry or Craig had any comments on the cytokine storm issue, specifically with pediatrics, but also with other individuals. And I think both of them alluded to it. how the immune system sometimes overreact and can cause a lot of damage.
My only comment would be that my understanding is that the remdesivir is often offered with a corticosteroid for that reason. So I'll defer to Perry since he clinically manages these patients.
So initially there was some concern that steroids would make this worse, because there is actual evidence out there that steroids on people who have a normal viral pneumonia actually have worse outcomes. But they postulate that that's because that allows the virus to increase its replication being unchecked by the immune system, which is suppressed by steroids. But there's a great study from the NHS service in England that showed that those who got low dose dexamethasone was helpful in outcomes. There are a lot of studies going on. Before I say that, as I was I had mentioned, is that in I think 2 of the 3 patients that or maybe all of them, it's in the day 7 to 10 window is when we're seeing patients that come back or have a worsening clinical outcome. And a lot of people think that day 7 to 10 outcome is related to that cytokine storm that's going on. And we often trend the inflammatory markers that are related to this. But that's a whole other talk for another day. But if we think they're very clearly in that cytokine storm, we give higher doses of steroids rather than those low doses of steroids. And we also are running studies now about specific molecules that we give to shut off the cytokine storm.
How long do you think the anticoagulants have to stay? Heparin or Xarelto, or when you're using blood thinners?
So what they recommend is, or at least our team, is a month of anticoagulants after, if you have severe COVID, about being on an anticoagulant for a month afterwards.
And I'm taking a few questions and turning into one. What do you use in New York to clean? You work in a place that has COVID. So do they use any special things to clean after a patient was x-rayed or diagnosed or whatever?
I don't believe that. Honestly, I don't think that they're doing any type of that much more extra cleaning. They're just being more thorough about it. The virus is not, it's not like a bacteria that lives in a spore that it's hard to kill. It's very sensitive to just normal alcohol wipes. I do believe that they're using basically the standard treatments that they were using beforehand, where it's the normal type of disinfectant and UV protectants. And there was actually very little nosocomial spread or within hospital spread in our hospital. I think part of that is that my hospital is much more resourced than the majority of hospitals, and our PPE, though we definitely had to ration it to dangerous levels, it was never as bad as other places. And people, and the only type of outbreaks we had were early on, when I don't think people took it as seriously as they should have. And a lot of people brought it in from their community and infected other nurses, unfortunately. And then from there, a few patients that didn't have COVID got it in their hospital. But as far as a known COVID patient giving it to a nurse and then a nurse giving it to other patients, there weren't many episodes, or I think any in my hospital. I think it was all from community spread, infecting the nurses, and then nurses then accidentally giving it to patients. And now, yes, go on. That's all.
No, go ahead.
And now we're so good at, everybody is screened once a week at the hospital, at least. If you're on a COVID-4, it's more often. And everyone is wearing masks to decrease that. So it's been I think at least in New York City right now, the numbers are so low that and people are so good at protecting you from it that one of the safest places to be if you have to go to work is the hospital.
Okay. Craig, can you, we're almost an hour and a half into the program, and I still have zillions of questions, but can you make like a time schedule on an average case? You know, the person gets infected. When he tests positive, and then, you know, what's the outcome? And then when can we say that he really doesn't have? Because some people have a PCR 14, 21 days and they still have coronavirus. Is it dead? Is it not infecting? Is it just in his throat? Can you do just draw us like a imaginary timeline?
I can. It gets a little complicated because it's easier if you say they're positive and they're a true positive right from the start. It gets a little more complicated if somebody gets a false positive or a false negative, which Michael, you know, goes into great detail on some of his lectures about. But it's very important for people to understand that a test is only as good as its accuracy and reliability and validity. So, you know, some tests are better than others, and if they're done properly, an RT-PCR reaction would be, you know, the gold standard. And if that comes back positive, so if somebody's infected and you inhale a virus, it's going to take a few days to build up sufficient levels for you to produce a viral titer test positive, so a PCR test. So you're probably not going to be positive within 24 hours, but you probably could be positive within 48 hours of being exposed. You produce enough, depends on how good the swab is and where, again, the virus landed. And then you'll replicate that virus for a period of time. You'll incubate it for, let's say, 2 to 10 days. Most people, it's 3 to 6 days, and then develop some symptoms. If they are going to develop symptoms, some are asymptomatic or pre-symptomatic. And then, as Perry well said, you know, they will go through symptoms for about a week, and then if they're going to get better, then by a week they start to respond. Otherwise, they start to go downhill between, you know, day 6 and day 10, and maybe they end up in the hospital because of low oxygen sats. So people can shed virus now for a long period of time. So that's well known. So people could be shedding for days, weeks, you know, 30 days possibly. And I don't know if you all are doing viral tests. I'm assuming if a patient's on a ventilator, you know, you're checking their secretions, or how are you all checking, Perry, to see that they're actually turned to COVID negative? When does a person become COVID negative? I'll toss it to you.
So what we saw in many of our patients, that they were positive for a month to almost 2 months sometimes. You know, the average person, not so, but I mean, our patients, they're older, maybe they're immunocompromised, and that's why they're not clearing all the virus. But there's a lot of evidence that, you know, about a week to 10 days after your initial onset of symptoms, you're no longer infectious, even if you have detectable virus. And there's also the question of whether detectable virus or detectable, the swabs that we're not doing viral cultures, we're doing RNA swabs. So you might have RNA that's floating around in that system that we're detecting, but we're not detecting viable particles. A lot of the concern we had is, when you discharge patients, you need to go to rehabs like a normal hospitalization. You know, they would require you to have 2 negative nasal swabs before they're willing to take you, at least 24 hours apart. Some needed 3, some needed 72 hours apart. And there were times where we would swap someone, they'd be negative one day and they'd be positive, you know, 24 to 72 hours later. And then it's a cycle. It's like you don't obviously want to bring it to that SAR, but there's also a lot of question, is detectable RNA the same thing as infectious virus? And the consensus is that detectable RNA does not always mean infectivity. But the understanding is that about 7 to 10 days, depending on the protocol of where you are and where symptoms started, 7 to 10 days after initial onset of symptoms, if you're feeling better for like 2 or 3 days in a row, you can probably say that you're no longer infectious and leave quarantine.
You know, we in the office, we treat everybody like they were infected. You know, this is the protocol, because you cannot decide, you cannot do a test. You can do a quick test, but it's not going to tell you necessarily if the patient it's the initial stage for day 3 or 4. Once the IgM and IgG start to, you know, that's a different stage. So we have to treat everybody like they were infected. But I would like to know about your feelings of doing this with patients that, I think it needs a special, mental stage to treat patients with cancer. But is it COVID makes it more stressful, or what? Forget the science. Talk to me from the heart.
Yeah. So I mean, I will say it was definitely very scary when everything first started, because we knew so little. The more you learn it in ways that it's scarier now than before, when you know more and more that even healthy early 30s are succumbing and having bad outcomes. It's scary, but you just kind of adjust to it. It's hard. I hate this analogy because it has not been as bad as, truly living through a war-like experience, but you have to adjust to it in order to survive. And kind of the more you're exposed to the clinical experience, the more used to it you get. And it's just part of life, is that there is this virus out there that, you take every precaution you can. I don't take the subway or like public transportation. I walk to work now, and I avoid all public crowds. I waited till a month after outdoor dining was out before I was willing to eat outdoors, because I wanted to track and make sure that there wasn't going to be a spike when we opened outdoor dining. It is something that you adjust to, and you have to make the safest decision you can. And it's all really about minimizing risk, because realistically, we all have to work, and we all need to live our lives as best we can. But how do we minimize risk from us getting any type of infection?
But isn't frustrating?
I think one of the most important part here is that we cannot become complacent, even though we know that this virus is going to be endemic, meaning we're probably never going to get completely rid of it. We have to keep a healthy respect for this virus because it's deadly. And becoming complacent, I think that's when we start to make mistakes. So I think what Perry said is very right, in the sense that you adapt to this new environment, but don't lose respect for the virus. It will kill you.
Yeah. Let me go to the last short video, and we have our final round. Okay. I don't want to finish this program. I knew it was going to be probably the best program we've done on COVID. And I have to thank you, Michael and Perry and Craig, for being here. But let's go to the video and come back. Corre video.
OrthoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrthoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%, libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrthoGuard, con 5,000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel, indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Oh, two more questions that I don't want to miss. Michael, this is for you. What is the best timing to do the test? The PCR and the serological test, blood test.
I think Craig mentioned it, but you can get infected, and until you have sort of accumulated enough virus, you may get a false negative viral swab, obviously. So the PCR may come back negative. The antibodies, they start after around 4 to 6 days, after around 10 to 12 days, up to 15 days, you have the antibodies. You have IgM and then you have IgG. How long the IgG is going to continue, no one knows, maybe up to 2 to 3 months, maybe not longer than that. Then they might wane, but as Craig mentioned, you may have B cells, memory cells that can activate it very quickly in case you get infected. So when it comes to testing, it's a completely different story, obviously. What you have to realize, though, there is a window period when it comes to the antibodies, meaning you are infected, antibodies have not developed yet, and you test yourself, antibody may come back negative, but that means just a window period, meaning you still have been infected, but antibodies are not there yet. That's the window period. When it comes to the PCR test, the problem we have with the PCR test today is the amount of false negative results that we get, unfortunately. So what you are doing in your practice, Jaime, is absolutely 100% correct. We treat everyone as if they are infected, because otherwise you're going to miss them, unfortunately. But I hope that answered your question.
Craig, why don't let's say the patient already has been positive, he has symptoms. Let's not talk about the asymptomatic. Why cannot you only spit and treat it instead of being technique sensitive when you push the cotton thing through your nose? Why go to the farthest part if the saliva is supposed to be full of it? Full of COVID, not full of it.
I agree. I think that physicians classically don't test saliva for hardly anything. And I've tested saliva for hundreds of different biomolecules, and it's easier, it's less invasive, and there are studies by Toe and others who have demonstrated that salivary levels can be equivalent, if not higher, than nasopharyngeal. Nevertheless, I suppose it is possible some patients could have higher titers. The correlations look quite well between saliva and others, but not everybody's going to be 1-to-1. And so, but I prefer testing saliva. I asked our lab here to consider doing it at the hospital. They weren't too interested. I didn't really push real hard because I felt I was going to be just banging my head against a wall, but I do think you can test saliva. It's interesting. I'll share with you, if you look at varicella zoster, so shingles, a disease that's a respiratory disease. It can be spread by a cough. If you break out in shingles, studies have shown that if you have shingles anywhere, whether it's in your head, neck, thorax, lower abdomen, sacral region, virtually everybody sheds the virus in their saliva, and they'll shed it for days, weeks. And that's not very well known by the medical community. They don't tend to test. They don't measure viral titers to see how long they should keep a patient on an antiviral, such as valcyclovir or famciclovir. Everybody gets a standard course of 2 weeks. But we know that at the end of 2 weeks, some patients are still shedding. And are those the ones that go on to develop post-herpetic neuralgia? Maybe, maybe not. Somebody needs to say that. It's a great research question that needs to be answered. So again, I'm hopeful that we start using the biological information to help us more. And at some point, I'm hopeful that, using saliva or some other secretion, gives you an accurate picture of what the patient's condition is in combination. It's an adjunct. It's not your only test. You're going to look at the pulmonary films, you're going to look at the symptomology and the signs of the patient, the oxygen sat, and you're going to put together a picture of what needs to be done next. But I do think the biological information can be captured from saliva.
Is it another example where medicine and dentistry are divorced?
There are plenty of those, Jaime. That's a completely different program that we're going to have, not where they've integrated or where they have diverted. And that's okay. We're going to have that for another time.
Yeah, I do think that, we don't lecture to the physician. I mean, as a dentist, I can go to grand rounds and listen to the physicians. And every now and then they'll ask me to give something on a topic, and I'll have the opportunity. But most of the physicians don't know a lot about the mouth, as Michael will say, and they don't know a lot about saliva. And so, they go to what they know and what they're comfortable with and what they know works.
Okay. Listen, I want to thank you because this is the first time that we keep Michael so late.
It's far beyond my bedtime. There's no question about it. It's
almost 4 o'clock, and he's going to go out golfing early in the morning. No, I don't know if you want to make a last comment. We never even reached to the vaccine stage, but if you want to make, all of you, a last comment, and then we're going to have to close the program because Michael has to go to sleep.
Well, I think first of all, fantastic presentations, both of you. Very, very helpful information. I think the questions from the audience were excellent. Perry, I didn't tell you, but there was one comment here from the audience. Great admiration. God bless you for what you're doing. And I think there are a lot of people that agrees with that as well, but it was actually written here as part of the comments. Jaime, I think we need to do this again.
Yes. Let's hope we can do it with a drink or with a beer or in a conference. No, we'll certainly invite you again because it's too much information in such little time.
Yeah.
Well, it's been my pleasure, and I do want to thank Perry and all the healthcare workers who are out there. I do think these forums are great to exchange information and an opportunity for learn, but Perry and the other physicians, nurses, respiratory therapists are right there where the rubber meets the road, and without them, people would not be surviving. So I personally thank you too.
Perry, Michael.
Thank you. I mean, for the admiration, but it doesn't mean anything if people aren't willing to wear a mask and it comes back. I don't want to go through what I went through before. So keep on. Wear a mask. Make everyone that you know wear a mask. It really, I think it not only will prevent you from getting it. I think if you get it, it'll actually decrease the amount of that viral load. So wear a mask. Wear a mask. Wear a mask. Social distance when you can. That's all I have to say.
Thank you.
I really want to thank you both. It's been a great program. A lot of you introduced us to a lot of information. And I hope that everybody that is still listening will really go and find more information. And also your personal touch. I want to thank you both. And Michael, as always, we're just going to go. We want to thank our translator, Dr. Samantha Arispe, which is always doing a great job at translating all this into Spanish. And we want to invite you next week. The program is going to be in Spanish. We're going to have, again, Dr. Mauricio Lisker from the VA at St. Louis, Missouri. And we're going to talk about hepatitis B and C, which we call the dentist busters. It's, in reference of the movie, the Ghostbusters. So thank you again. Thank you, Perry. Thank you, Craig. Thank you, Mike. Go to sleep. Sleep tight.
Thank you all very much. Have a good evening, everybody.
And to everybody in the audience, thank you for being with us so late. We'll see you next week in Spanish and in 2 weeks' time with a very, very interesting program.
Adiós.
Si te lavas bien las manos, lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Mas no olvides que tu boca es otra fuente de infección. Cepillarte bien los dientes te protege.